Let's talk about transient tachypnea of newborn in today's video. In TTN, T stands for transient, means temporary. Tachypnea means when baby is breathing rapidly, so normally baby can breathe up to 60 times a minute. If they are breathing faster than 60 minutes, then it is considered as a tachypnea, and N stands for newborn. It's got lot of other names. It's also called wet lung syndrome, type 2 respiratory distress syndrome, and postnatal pulmonary edema. TTN is benign self-limited condition that can present in infants of any gestational age shortly after birth. It is caused due to delay in clearance of fetal lung fluid after birth, which leads to ineffective gas exchange, respiratory distress, and tachypnea. In the NICU, it often poses significant diagnostic dilemma in the care of newborn babies with respiratory distress. Epidemiology: about 1 to 2% of all newborn develops TTN. It is the most common cause of respiratory distress. So around 40% of the respiratory distress in newborn is due to TTN. The main factor associated with TTN is delayed resorption of fetal lung fluid. During pregnancy, the lungs are filled with fluids. How does the babies get rid of this fluid before baby is born? This is done in 3 different ways. First, onset of labor with uterine contractions stimulate production of hormone in fetus and mother, causing fetal pulmonary epithelial cell to begin resorption of fluid. Second, during the process of vaginal birth, the fluid is squeezed out of lung, so anything that interfere with spontaneous natural labor, as in cesarean section, will delay resorption of fluid, leading to TTN. Third, after the birth, crying and breathing of baby pushes the remaining fluid back into the blood vessels in the lung. So these are the 3 mechanisms by which the resorption of fetal lung fluid happens. Risk factors. Maternal risk factors include delivery before completion of 39 weeks of gestation, a C-section without labor, and gestational diabetes. Fetal risk factor includes male gender, small for gestational age, and large for gestational age. I have made a very beautiful video on newborn. Link is in the description box. Clinical feature. The condition presents within first few minutes to hours after birth. Physical exam finding usually include sign of respiratory distress, tachypnea rate greater than 60 per minute, nasal flaring, grunting, intercostal, subcostal or suprasternal retractions, crackling or normal breath sounds on auscultation. Diagnosis. Duration of respiratory distress is the principal determinant for the diagnosis of TTN. If distress resolved within first few hours of the life, it can be labeled as delayed transition. 6 hours, arbitrary cutoff between delayed transition and TTN, as by this time baby might develop issues with feeding and might require further intervention. So TTN is usually a diagnosis of exclusion. The workup usually include preductal and postductal saturations to rule out differential cyanosis and cardiac causes, complete blood count, blood culture, and C-reactive protein to rule out neonatal sepsis. Blood gas may show hypoxemia and hypocapnia because of tachypnea. It may also show hypercapnia as a result of respiratory fatigue or air leak. Chest X-ray may show fluid in interlobar fissure, hyperexpanded lung, flattened diaphragm, prominent vasculature in sunburst pattern, alveolar edema appearing as fluffy density, and no area of consolidation. Management. Given that TTN is a self-limited condition, supportive care is the mainstay of treatment. Routine NICU care including cardiopulmonary monitoring and maintenance of neutral thermal environment should be initiated. Neonates' respiratory status is the usual determinant for the degree of nutrition support required. Tachypnea of over 80 breaths per minute with associated increased work of breathing often makes it unsafe for the infant to receive oral feeds. Such infant should be considered for IVF, intravenous fluid, if respiratory distress is resolving and diagnosis is certain and respiratory rate is lesser than 80 per minute, enteral feeds can be started. Oxygen support may be required if pulse oximetry or blood gas suggest hypoxemia, and oxygen hood, nasal cannula or CPAP could be used. Since TTN may be difficult to distinguish from early neonatal sepsis and pneumonia, empirical antibiotic treatment should be considered until infection is ruled out. Randomized control trial studying the efficacy of furosemide as well as racemic epinephrine in TTN showed no difference in duration of tachypnea or length of hospital stay compared with control. Prognosis. Overall prognosis is excellent, with most of the symptoms resolving within 48 hours of life. In some cases, malignant TTN or toxic TTN has been reported, in which affected newborns develop persistent pulmonary hypertension due to possible elevation of pulmonary vascular resistance due to retained lung fluid. Thank you for watching the video on TTN. If you like the video, please like, share and subscribe.